Hello and welcome to Inpatient Update. I'm your host, Mason Turner, and this is your podcast for practice-changing evidence for the working hospitalist. Today on the show, I'll discuss phenobarbital for alcohol withdrawal, frequency of hemodialysis in folks in acute renal failure, and transfusion goal in postoperative patients. Well, welcome back to episode 2. As a reminder of the format, we'll discuss 3 recent practice-changing articles in less time than it takes you to finish your morning cup of coffee. The idea is that we get you a quick download of the most recent evidence that will actually impact your practice tomorrow. Recording another solo episode today as I continue to iron out the format. But in the future, I'm certainly actively recruiting guests and would like to have a guest on every episode to discuss. So if you're a provider, a pharmacist, a nurse, a resident, a student, or anyone with some value-added insight in the management of the hospitalized patients, please text me, DM me, or email me at podcast@inpatientupdate.com to reach out and to get on the show. I'd love to have you. So let's get right into it. First, we'll start off with an article regarding phenobarbital use in alcohol withdrawal. So this was an article called Fewer Admissions, Shorter Stays, Phenobarbital Use for Alcohol Withdrawal in the Emergency Department. And it was published this year in the Journal of the Academic Emergency Medicine. Picked this article because despite it not being a randomized control study and instead being a retrospective cohort study, I found it interesting and exciting because they used a natural experiment. And my undergraduate degree was in political science. And so working in the soft sciences, they're always looking for natural experiments because you can't really perform randomized control trials on major things. So I had a little soft spot for this natural experiment here. And what prompted this study, or one of the things that facilitated it, was the IV Ativance shortage we recently had. And so given that IV Ativance shortage that I think started in 2020 or 2021, the protocol for several emergency departments changed so that IV Ativan wasn't the default they gave to folks that came in for alcohol withdrawal. And so that opened it up to other things that folks had to get creative and use other medications. And so phenobarbital was a major medication used. And that allowed us to, in retrospect, compare the use of benzodiazepines versus the use of phenobarbital versus using some of both. And so this was a single center study, but it looked at 777 ED encounters for folks coming in acute alcohol withdrawal. And so 53% of those folks had phenobarbital only, 19% were benzodiazepines only, and 28% were a mixture. And so what they looked at, the primary outcome was percentage of these folks that got admitted to the hospital. But then they also looked at some secondary outcomes as well. And we found a significant benefit in reduction in hospital admissions in the phenobarbital group. So for the benzo group, 74% got admitted. For the combo group, about a 12% reduction, 62% got admitted. Dropped down another 10% for the phenobarbital group to 52% of those folks got admitted. And this was a statistically significant odds ratio when comparing phenobarbital to either of the other two groups. And so for phenobarbital versus the benzos, odds ratio of 0.44, and again was statistically significant. And then for phenobarbital versus the combo group, 0.65. And so one of the secondary outcomes they looked at that was interesting was also length of stay in the ED. How long did these folks get stuck in the emergency department? For the phenobarbital only group, the length of stay was 5.8 hours versus 7.6 hours in the benzo only group. which honestly seems like a pretty quick stay in the ED. I'm sure my folks who work in the emergency departments would agree. I presume this is time to disposition and not amount of time they were stuck boarding down there, which particularly in these deep COVID times was quite often quite long. Um, and again, obviously limitations in this study, given it's not a randomized control study, and so there's major obvious selection bias, and that providers weren't actively choosing what they did to try and randomize or be even. They were making the decisions for a reason. So it is possible that the phenobarbital group were just less sick patients, and so they ended up um, not getting admitted as frequently. But this lines up with something we're seeing more and more, and something we're moving to in our institution, and I believe a lot of institutions, of using more phenobarbital in the emergency department and the ICU and every part of the patient's care. It's not something that I'm very comfortable with. Honestly, when I was in medical school, the discussion around phenobarbital was like this was archaic medicine that had been essentially completely replaced by the use of benzodiazepines. But then it's come back really powerfully to use for folks in just this situation, to load them up front because it's got a very long half-life and kind of naturally tapers for people. It's become a great medicine to load people at alcohol withdrawal with up front, and get really good control of their alcohol withdrawal symptoms from the outset, and then naturally taper off. And so that allows it so you can loading the patient up front rather than chasing it with something like CWA. Loading them with this long-acting medicine gets their symptoms under control quickly, which would facilitate them getting discharged. But also, it because it naturally tapers, they don't have to worry so much that they're gonna discharge them and they'll just rebound back. In theory, with a good protocol, you should be able to load these people up front and pretty much be done and not even need this combination therapy they mentioned, yeah. So this, like I said, is not something that we are totally actively doing at our institution. Down in the emergency department, they do seem to have very thoroughly adopted this, but up on the floor in the inpatient side, we don't do it quite as frequently. But I'm excited about doing it more and more, and it does seem that the literature is going this way, and I do anticipate it'll be something we talk about the show on again, and probably some more rigorous trials. But I know recently I had a gentleman who came into the emergency department. I was being told about the patient the next morning because they had come in overnight. This patient had called from home because he was hallucinating someone else in the bed with him. He was brought in to the ED. Really, all he was having was some weird mental status stuff and hallucinations. And so the ED, I think, basically disposed him as too sick to go home, not sick enough for the ICU, this hallucination stuff, probably too medically complicated to go to the psych ward, so it's midday medicine, and they just put him on a CWA protocol with PRN oral lorazepam for treatment. And I'm hearing about this patient the next morning and hearing about these hallucinations and hearing about their history of, a pint of vodka a day reported, and supposedly had some Wernicke's, which maybe we're blaming these hallucinations on. And I'm all hearing a very strong drinking history. But I'm seeing CWA's documented only like somewhere around 7 or 8. And I'm worried that it's about to come. This alcohol withdrawal that this gentleman is having is really going to show itself. And he did not get loaded in the emergency department with phenobarbital because he was not actively showing enough symptoms of that alcohol withdrawal. But by the time I walked into the room, the nurse is grabbing the team and saying, "Hey, I think he maybe needs a dose of the Ativan." And um, we go in there, and then this gentleman is tremulous to the point that he can't hold his fork, clearly hallucinating things on his plate, totally out of it. And he says, "I think I'm withdrawing from alcohol and I just need some Ativan to get straight." And it turns out he was right. This gentleman, we coordinated with our pharmacist, started loading with phenobarbital. But given this was the first moments, I mean, he came in with alcohol level of 0, but this was clearly the first moments of his DTs, and he was escalating quickly and actually ended up in the ICU for 24 hours or so, but then was um, really didn't need a ton there because we did, working with pharmacy, load him with phenobarb. Didn't need a ton, that wasn't scoring a ton on CY after that, didn't need a ton of additional benzos or other meds, and then was able to transition out in the ICU to the floor and then home within a couple of days. And I'll tell you, he was a totally new man by the time I saw him, probably a day and a half, 2 days after we sent him up to the unit. Um, Totally coherent, totally with it, clearly not hallucinating. But the phenobarbital is incredibly powerful, and I'm excited for this becoming more of a mainstay of our treatment of inpatients with alcohol withdrawal symptoms. All right, on to the next article. So, um, probably one of the most common reasons I feel like I'm sitting around watching a patient stuck in the hospital who feels pretty much fine, but feels like they're going to be in the hospital for eternity is the monitoring for renal recovery patient. Um, I had just last week a lady with multiple myeloma who, severe CKD in the setting of the multiple myeloma and other comorbidities, CKD4 coming into hospital, came into the hospital for some other reason, had some complications, and toppled over into an AKI requiring renal replacement. Spent a little time in the unit, but came out stable. Um, but still requiring intermittent HD. And in these patients, as I'm sure you've had, there's always a question of exactly how frequently should I be doing this HD? When should I not be doing this? It's HD. Is their renal function going to recover, and are they going to be able to go home without dialysis, or am I getting a tunnel line for this person, coordinating with my dialysis coordinator and waiting for days on end for them to get accepted to a dialysis unit before they can go? And so in that patient population, um, the question of how frequently do we do HD is always kind of present. And my intuition is always we won't truly know whether or not they need HD unless we give them a chance to fly. And so this study kind of looked at this. This was the LIBERATE-D trial, an article entitled "A Conservative Dialysis Strategy and Kidney Function Recovery in Dialysis Requiring Acute Kidney Injury," and was published in JAMA just in January of 2026. This was a multi-center randomized superiority trial. The N was 220, and the population was specifically hemodynamically stable adults with an AKI requiring dialysis. So this is, when I say hemodynamically stable, the important part here is basically anything that would mandate you're in the ICU was in an exclusion criteria for this patient. So they can't be on the vent, they can't be on pressors, etc. So this was the inpatient. This was the patient I'm talking about who's stable on the floor. We're just waiting to see, are they going to need HD? Are they not going to need HD? And so they broke so the intervention group was they called a conservative dialysis strategy, and conservative meaning we only do it if it really looks like they need it, versus the control was a conventional strategy where we just put these people on the railroad track of 3 times a week dialysis while we kind of monitor numbers for them, like all of our others, or generally our folks with ESRD. And so in the intervention group, the conservative group, the criteria for doing dialysis were a BUN greater than 112, a potassium greater than 6, severe metabolic acidosis, pulmonary edema with hypoxemia present or some other clinical judgment that this person acutely or clearly needed an HD session. Uh, Notice too, I'm sure it would be the chagrin of many of my patients or med students that creatinine, thankfully, is not a criteria there at all. So the primary outcome was time to and well, really percentage with recovery of kidney function. Um, and that's either at the time of discharge, really at the time of discharge from the hospital. And so that was basically what's the group of the people that percentage of them that are going home without dialysis versus those who are ending up on dialysis when they leave the hospital. And in this trial, we found that the intervention, the conservative, the group, the only when needed group, 64% of those folks had renal recovery and were able to go home without dialysis versus 50% in the 3 times a week conventional group. And so that was an odds ratio of 1.76 that was statistically significant with a 95% confidence interval of 1.02 to 3.03. So we saw a great result here, an interesting result here, that if you don't put these people on the railroad tracks of regular dialysis, that they actually are more likely to not end up being stuck on needing dialysis. Now, in this study, because the N was relatively small at 220, they did do a adjusted odds ratio as well, where they controlled for baseline GFR, age, sex, race, and in that, there was still a signal that there was better outcomes in the intervention group, the conservative group. The odds ratio was 1.56, but was not statistically significant in that group. So, um, and then there were a few other things they looked at. The conservative group was associated with less frequent hypotension. No surprise there. We all know how much dialysis drops folks' blood pressures. Obviously, less total dialysis sessions per week and overall throughout the hospitalization. Um, so really powerful here. My takeaway is we should be encouraging our nephrologists to only do dialysis when we're actually seeing it needed in these patients that are AKI requiring dialysis, questionably ESRD, because we're more likely to have a better outcome. I get the impression sometimes it's kind of easier scheduling to just have them on the 3-day-a-week schedule, but these other things they looked at, which obviously not needing the dialysis unit quite as much, would in total obviously decrease the demand on that HD unit, um, which is going to be really positive. Less patients needing HD is going to free up the schedule some. All right, and on to our final study. So if your hospitalist group is like mine, then you do some co-management with surgical services. This is a pretty common thing, lots of data. As my boss emphasizes that this helps outcomes for patients, um, to have hospitalists on board for folks admitted for surgeries. And there's also something to do with CMS reimbursement of bundle or something like that. So very popular to have a co-management with for hospitalist services working alongside with surgical services. Um, Otherwise, of course, we as hospitalists, if it's not a co-management service, we're often the primary on folks who have had surgery. And when I am doing this co-management service and I've got a 78-year-old lady who's got a hip fracture and is getting it repaired and has a history of a stent 8 years ago, no other significant history. There's always the debate of when to start giving her blood and if she needs blood. And there sometimes seems like there's a little bit of an ideologic difference between the surgeons and um, the hospitalist of aggressively or early giving blood, but once the seal is broken and we've started giving the patient blood, we're usually on the same page of let's transfuse this patient if it's needed. But the question is, when is it needed? And so this is that classic caveat. We've got this sort of dogmatic hemoglobin of 7, less than that we transfuse, that we all know, and we've all heard whispers and discussion of whether or not that's really based on good evidence. And then with the caveat of it's 7 or it's 8 or maybe 10 if they've got coronary artery disease or an active heart attack or something like that. But I feel like in practice, there's just kind of this wishy-washy, like, oh, I decided to transfuse them extra because of maybe they have an insemi this day, or maybe they have a history of coronary artery disease, and it seems a little inconsistently applied. And this is an area where we're getting lots of active research of what should these numbers for transfusions be. Because despite the fact that everything we say when we consent someone for blood is um, a lot of that sounds horrifying, but is really archaic and very rare. Giving a unit of blood isn't without its complications, and so we want to know exactly when it's worth doing. Um, so this was a study, 2025 study in JAMA entitled "Liberal or Restrictive Postoperative Transfusion in Patients at High Cardiac Risk." It was the top trial. Um, and so it was a randomized trial with 1,428 patients. This was done at VA centers, and so obviously these patients skewed male, skewed about 70 years, I think was the average age for these patients. But it was folks that had a high cardiac risk after having a major general surgery or vascular surgery were the surgeries they included. And they called high cardiac risk anyone who had a history of coronary artery disease, had had an MI before, had peripheral artery disease, or had a CVA or TIA in the past. And so the intervention was liberal transfusion. So anyone with a hemoglobin less than 10 got transfused. So goal maintaining hemoglobin greater than 10 versus restrictive goal maintaining hemoglobin greater than 7. And they looked at a composite outcome of death, MI, acute kidney failure, stroke, or need for revascularization within 90 days. Um, and headline, what we saw here was pretty much it was a coin flip. So for the primary outcome, the goal 10 hemoglobin of 10 group, the liberal group, 9.1% had the composite outcome. In the restrictive group, goal hemoglobin 7, 10% had the composite outcome. Relative risk of 0.9, obviously not a statistically significant result there. But there was a secondary analysis looking at cardiac complications that weren't ischemic, non-MI, specifically arrhythmias, heart failure, cardiac arrest that didn't end in death. And there was a statistically significant better outcome in the liberal group with 5.9% having those outcomes versus the restrictive group with 9.9 with a relative risk of 5.9 and again statistically significant, but that was the study wasn't designed for that outcome. That was a secondary analysis there. So big picture, even with liberal transfusion, aggressively transfusing these folks who have this coronary history after surgery, we don't see really significant improvement. There's maybe this little bit of a secondary finding, which It's hard to know what to make of that. The arrhythmias, I'm kind of thinking maybe this is almost a volume standpoint, and that these folks are hypovolemic, they're more likely to go into AFib or other tachyarrhythmias, which obviously we see that a lot, that these folks are hypovolemic after procedures, and that's often kind of masking the hemoglobins and kind of complicating this whole picture. And so this may have been honestly a way to just volume resuscitate folks better, and maybe why we got some of those less arrhythmias. But the point is, um, hemoglobin of 7 seems to be just as good as a hemoglobin of 10. And obviously, you're going to be using less blood if you do that. And so I will, for my practice, continue to use that hemoglobin threshold of 7 unless they have some other reason, like they're actively bleeding or they're having active ischemia, having an MI and a STEMI, then certainly would be more aggressive with my transfusions, but we'll continue just to hold the 7 line um, for folks after surgery. All right, and thank you so much. So those were our 3 articles. Again, the key takeaways are for folks who come in with alcohol withdrawal, think about loading with phenobarb rather than just chasing things with benzos and CWAS, um, and push for your institution to look into starting a protocol for that. When it comes to HD, if you got someone who has an AKI requiring dialysis, only dialyze them when they need it. If they don't need it, don't dialyze them. They're more likely to have recovery of their renal function that way. And lastly, for folks who have surgery, even if they have a history of uh, high risk cardiac issues, you can still use a conservative hemoglobin of 7, keep it classic, just transfuse to 7 even in those patients. Thank you so much for listening. Again, if you'd like to be on the show, I'd love to have you. Reach out to me at podcast@inpatientupdate.com. Follow me on Instagram, follow it on Twitter. Make sure you've got this in your podcast feed so you get the next updates. And thank you so much for joining me. Goodbye.